Good evening. Welcome. So my name is Brad Monk. I'm a gynecologic oncologist from the University of Arizona Cancer Center in Phoenix. It's my esteemed pleasure to welcome you along with my faculty. I'm here with Dr. Tom Herzog from the University of Cincinnati, from Ursula Marcelonis from the Dana-Farber Cancer Institute. Thank you very much for being with us at this symposium. Thank you. So this is the symposium entitled The Clinical Potential of Novel Poly-ADP Ribose Polymerase Inhibitors for Improved Management of Epithelial Ovarian Cancer. Our mission today is to help in improving the management of epithelial ovarian cancer. We're really focusing on PARP inhibitors. If it hasn't dawned on you, it was 1992, the year that I finished my residency, that the gynecologic oncology space brought you a very important chemotherapeutic agent, paclitaxel. 1992. It was done in ovarian cancer, and we're here to talk about tonight what we did in 2014. Again, in ovarian cancer, bringing you a new agent, a PARP inhibitor, olaparib. And I'm not sure whether or not olaparib will transform solid tumor oncology the way paclitaxel has, but it might. And I think you're seeing PARP inhibitors becoming more and more common, not only in the current FDA indication, which is only since December 19th, but it's really an exploding field. And we're going to really try to hone in on that area. We're going to focus on the research findings to date, looking at efficacy and side effects, and try to put this into clinical practice now that these novel agents are available, discussing some challenging cases, and then ultimately Dr. Marcelonis is going to talk about the ongoing clinical trials in a look forward. We're going to try to make this interactive. We're interested in your feedback, and we're also have a lot of discussion points amongst our group. So I'm going to spend just a few minutes talking about BRCA, the germline mutations and the clinical and mechanistic issues relative to PARP inhibitors. These are my disclosures. It's important. The ones that are particularly relevant here are Tesaro, Myriad, and certainly AstraZeneca. So I think it's no secret that it's all about individualization as we treat epithelial ovarian cancer. And one of the easiest ways to individualize therapy is to do it based on histologic subtype. It's not enough. Histology is a relatively blunt instrument or tool in finding and determining the best way to treat ovarian cancers. It still brought us a lot of discovery. I think we recognize that high-grade serous tumors and high-grade endometrioid tumors, which represent about 85% of the patients that are enrolled on our large phase 3 clinical trials, are those that are most susceptible to chemotherapy. I think we also realize that mucinous tumors have a biology that recapitulates colorectal cancer, that clear cell cancer also has some similarities with renal cell carcinoma, okay? But it's the high-grade serous cancers, particularly, that have BRCA dysfunction, but we're also here to tell you that BRCA dysfunction is present across all tumor types. So histology is important, but it's not just about high-grade serous tumors. So BRCA, all of you know it. I think we need to publicly thank Angelina Jolie. She has done more for the testing of BRCA among women than any of us ever could. As you know, it's a tumor suppressor gene responsible for homologous recombination DNA repair. I'm going to describe to you what that means. Basically, it repairs double-stranded DNA break. In fact, you may have heard at this meeting that a surrogate marker for double-stranded DNA breaks are loss of heterozygosity, or what people call genetic scarring. So you'll hear us refer to that, and that's what we're talking to. It's inherited in a dominant fashion, meaning that a son or daughter of an affected individual has a 50% chance of inheriting it. BRCA1 is more commonly associated with development of ovarian cancer, somewhere between 35 and 46%, but still even BRCA2 patients have a 13 to 23% risk. And again, most cancers are high-grade serous or high-grade endometrioid, as I alluded to in the prior slide, but certainly that doesn't represent the entire spectrum of BRCA-associated epithelial ovarian cancer. So there's a lot of discussion about what tests are available. We're here to talk a great deal about olaparib as well as other PARP inhibitors. With the current FDA-approved olaparib, Those are only FDA approved in patients who have a germline mutation, and that companion diagnostic that's FDA approved is called BRCA analysis CDx. It's a product made by Myriad. There are other, certainly, vendors. There are other multi-gene tests, which we might talk about later, depending on the discussion. And there's also a 3-gene panel that's particularly relevant to Ashkenazi Jewish women. So one of the questions was, what does the NCCN say about it? Well, the NCCN says that if you're a part of a family with a known mutation, then you should be tested. In other words, if your first-degree relative has inherited a deleterious or suspected deleterious mutation, that individual should be tested. It's pretty complicated in breast cancer, and I wrote it here for you, that the personal history of breast cancer and BRCA testing is dependent on the age and the type and the number of blood relatives that have it and the Ashkenazi Jewish ancestry. But in ovarian cancer, it's simple. You don't need to memorize anything, okay? The NCCN recommends that all women with epithelial ovarian cancer be BRCA tested. And they should be tested for 2 reasons. Certainly so that the family can consider risk-reducing surgery, but relevant and germane to our discussion tonight because it allows therapeutic options. And it's also prognostic, as you'll hear. Patients who have germline BRCA mutations have a higher response to chemotherapy, and they live longer. And then the final would be a male breast cancer survivor. So what happens here is that PARP repairs single-stranded DNA breaks, okay? And if you can't repair a single-strand DNA break, it causes a double-stranded break. And double-stranded breaks are repaired with BRCA. That's the association. Now, BRCA is not the only method that double-stranded DNA breaks are repaired. There are other methods, but it is the main method, okay? And so there's again, PARP repairs single-stranded DNA, which leads to double-stranded DNA. Double-stranded DNA, one method of repair is homologous recombination repair, and that's what BRCA does. So if you have a dual hit, PARP inhibition and an inherited BRCA mutation, that dual hit leads to apoptosis and hence what we call synthetic lethality. And this has been shown many times. There was a very pivotal series of papers in Nature in 2005 that shows that PARP is a huge, that BRCA dysfunction is a huge predictor of PARP apoptosis, okay? And that they are absolutely, acutely and absolutely sensitive to PARP inhibition, okay? And this was a very remarkable discovery. I would not be surprised if this leads to the award of the Nobel Prize. So you can also add PARP inhibitors to chemotherapy, so a potentiation, if you will. The difficulty, as you've seen here at this meeting, there's 2 abstracts on that, and it's also been shown before, that when you begin to add PARP inhibitors and chemotherapy together, they also enhance toxicity, so you have to reduce the doses. So most of the research, not all, and you'll hear about ongoing research, but most of the research has been used as a single agent in patients who have inhibited homologous recombination repair, or at least deficient homologous recombination repair, the double hit, and there leads to synthetic lethality. So again, summary and key points. This BRCA analysis CDx is the FDA-approved laboratory test for the use of PARP inhibitors, olaparib, and the mechanism of action involves targeting cells where the DNA repair pathway is impaired, signaling apoptosis. So we're going to take a few minutes here and take some discussion, and you can enter questions on your iPad. But I'm going to begin with talking to, I got one right there. I'm going to begin to ask our panelists, how common do you think the community is in testing for BRCA? Do you think that everybody gets it? Or do you think that there's something that we as a group need to go out and to be ambassadors or missionaries and teach that to the clinical community?
Brad, that's a good question. I think that community oncologists are definitely getting better at testing all patients who have ovarian cancer for germline BRCA mutations. I definitely, in my practice, as soon as a patient's diagnosed and comes into the office, post-diagnosis, that sets off a referral to the genetic counselor. So I do the testing up front so it doesn't get forgotten about.
Does it change your treatment as you move through the treatment paradigm if they're BRCA positive or BRCA negative?
I start thinking about two things. One is certainly potentially enrolling onto a PARP inhibitor trial, which we'll talk about later. And then certainly also really informing her family where they can undergo certainly life-prolonging and really important risk-reducing surgery.
So Tom, I have heard, and I actually happen to be one of these groups, that test out of my office without referral to the genetic counselor. My patients don't have necessarily funding for a genetic counselor. So I look at the genetic counseling mechanism as a barrier. That may be heresy. But when I do a referral to the genetic counselor, their insurance denies it. They're told it's going to cost $300. She says, I don't have it, and it doesn't get done. But the opposite is if I test them and they're positive, and then I go for authorization, I say, look, this woman has BRCA, she needs genetic counseling, then the insurance company says no problem. So there's a controversy here, and I'm sure it's diverse in the group. Tom, do you routinely use genetic counseling, or do you test out of your office?
So that's a great question as well, Brad. I think for me, it's really one of the ideal situation and the practicalities of what actually occurs. So the ideal situation is that these women should have genetic counseling. There are so many nuances, and it's such a rapidly changing field that that is the best care, in my opinion. Now, the problem is, as you bring up, one problem is economics. Another problem is actually just workforce availability. And we have a shortage of genetic counselors that can meet the current demand, and this demand is going to grow exponentially. So I think we need to think about how are we going to manage this problem moving forward. Can we leverage technology? Can we do some online training for both physicians and patients about some of the issues? I think there's a lot of things we need to consider. One of the barometers I use, which is very practical, is I start talking to patients about genetic counseling and genetic testing and going over some of the fundamentals. And I sort of tell them patients tend to sort themselves into two groups. One with lots of questions and lots of things that they want to have great detail to take home, and others that just say, look, I just really want to know if I'm positive or negative, in which case I then triage internally based on that. I do think there are patients who absolutely need to go on and get genetic counseling, and that is, again, I think is best practice. But it's just not practical to have counseling for everyone at this point. So it's a problem.
It's helpful. So Ursula, one of the members of the audience is why do we need to test the rare histologies, the mucinous, the clear cells cancers? I said that the most common phenotype is high-grade endometrioid and high-grade serous.
So I would concur that high-grade serous cancer is probably the histology that has the greatest proportion of and frequency of having underlying germline BRCA mutations, but certainly mutations are seen in all histologies. Granted, mucinous tumors have a very, very low risk of having, patients having a germline BRCA mutation, but I think that the importance of what we've been discussing in terms of potential therapeutic options for these patients and also the family history, I think to have a guideline like NCCN does that basically says testing for all subtypes, especially given mixed subtypes, you'll have mixed, clear cell serous or, endometrioid serous. You want to take the kind of guessing and the responsibility away from the pathologist and just focus on ovarian cancer.
Right. So, and I can tell you some personal experience with low-grade serous tumors. So, although the two-tiered system between low-grade and high-grade, the grades 2 being high-grade, although that sounds very simple, and indeed it is in about 80% of cases, but there are that 15 to 20% of cases where it's just not that clear. So that's another reason to test those. And then, Tom, one final question from the group is that are there comparisons between the different technologies? In other words, has one company's BRCA analysis been compared to another? because what's the evidence that one is better than the other? Because as it stands, there's only one test that's FDA approved.
Yeah, so this is an emerging and rapidly changing field. I spoke to that point when we discussed the role of genetic counselors, and we didn't even get into discussing variants of undetermined significance, how you follow those up, et cetera, which can be problematic for the clinician. When you start testing on your own, you need to have a plan. To your point, what about these tests, and are they different? They're even evolving internally within the companies in terms of the number of genes they're offering and everything else. As a whole, I think the fidelity of these tests continues to improve as our technologies improve, and I'm fairly comfortable that a number of labs are able to, within reason, give us the right answer on whether there's a BRCA mutation or not. But there are some subtle differences that certainly need to be addressed between companies.
Yeah, so I'm not sure anecdotes are helpful, but I was treating a woman on a lap rib, and her daughter came to see me from a different practice who had epithelial ovarian cancer as well. And I said, have you been tested for BRCA? And the daughter said, I haven't, I'm negative. I said, well, let me see. So she showed me the test from a different lab than the mother, and the daughter had the same mutation, but it was a VUS by one lab, but at the other lab, it was a deleterious. Now, you could argue which one was right, but I'm telling you, I had the same mutation in the same family with discordant results. So I agree with you, it's an evolving technology, and I think it's going to become clearer as we test more and more patients, but it's not as simple as it may sound. That was actually very interesting to me. Well, that's great. You asked some other questions related to the efficacy of PARP inhibitors, and we're going to get to that. And so we'll address your questions as the evening progresses. But I'm going to go ahead and turn the time over now to Dr. Herzog, who's going to talk about some of the clinical data on PARP inhibitors and where we are today. Dr. Herzog.
Brad, thank you very much. It's a pleasure to be here in warm and sunny Chicago. I can see why everyone's here. You probably all just guessed at the Hilton and didn't want to go out tonight. I don't blame you. So in terms of learning objectives, we want to evaluate the benefits and the risk of emerging PARP inhibitors in the treatment of BRCA deficient ovarian cancer. In terms of disclosures, I've served as a scientific advisor on advisory boards for AstraZeneca, Morphotek, J&J, and Roche. So I think that when we look at this, you'll notice this is the second time you've seen this slide, and that's because this is really quite a sentinel observation that was made. Two Nature papers in 2005 really looking at the whole concept of wild-type BRCA homozygous versus homozygous deficient versus heterozygous. And as you can see, the heterozygous, all you need is one copy of BRCA and you're okay. If you lack both, the cells are easily killed, and that's certainly problematic in terms of survival. So a lot of data there, 1,000-fold difference in terms of survival, looking at the differences there. So quite impressive in terms of what was seen, and I think there were a lot of proof of principle concepts that came out of this in terms of looking at BRCA1 versus BRCA2. There were certainly the fact that you could treat with a PARP inhibitor and that it was highly tumor specific were all concepts that came out of these publications that I think really were the underpinnings of the clinical development programs by a number of pharmaceutical companies. This led into a well-publicized phase 1 that was actually an expansion cohort in which they took 60 patients, 22 of which were carriers for BRCA1 or 2, germline mutations. Pharmacokinetic data indicated rapid absorption and elimination for the drug that was being tested in this, which was an AstraZeneca compound and became olaparib. The anti-tumor activity was reported only in mutation carriers, all of whom had either ovarian, breast, or prostate cancer and had received previous multiple regimens for treatment. The conclusion was that olaparib had few of the adverse effects of conventional chemotherapy, that it effectively hit target, as there was a translational correlate for the study, and it had anti-tumor activity in cancer associated with both BRCA1 and 2 mutations. So this is looking again at activity, and to stress some of what we're talking about tonight, whether we're looking at RECIST or GCIG responses here. You can see that patients did respond, whether they were platinum sensitive or resistant. There was a trending, of course, towards those that were platinum sensitive, but it is important to understand that there are those who are platinum resistant who have a mutation who still respond to PARP inhibition. The other thing that's important, again showing how important this particular paper was, this is a phase 1 expansion that was published in the New England Journal of Medicine. So not a bad resting place for a phase 1 study. This is phase 2 trial of PARP inhibition with olaparib in BRCA deficient advanced ovarian cancer, looking at efficacy, and we learned several things from the ADAY trial. One of which was that olaparib at 400 milligrams BID is more effective than 100 milligrams BID. If you focus on the progression-free survival difference here, you see 5.8 months versus 1.9 months. The other thing is that, importantly, you see responses both in platinum-sensitive and platinum-resistant disease, and I think that's important to understand at either dose there. And then we started to have a picture of the emergent toxicities that we would see with these compounds as well, and it gives you a pretty good idea. And we see that with increasing the dose to an area that we would be more comfortable with clinically in terms of response, you see that we go up by a factor of 3 or 4 in terms of discontinuation due to adverse events or to dose interruptions secondary to adverse events as well. If we look at phase 2, BRCA mutation ovarian cohorts, this is the waterfall plot here, and you can see the third or fourth principle we learned from this particular phase 2 study was that it didn't matter if you were BRCA1 or BRCA2, the PARP inhibition worked very effectively on both, and that's certainly clearly seen there. So if we look, we just featured the ADAY study right here, and I just talked about that in terms of the breakdown between the 2 different dose levels, and we can see how heavily pretreated most of these patients are. We're going to look at some other phase 2 data here. Karen Gelman had a smaller study, but looking at patients treated with olaparib at 400 milligrams BID and had up to a 41% response rate. And then Rob Coleman presented the GOG data that was recently presented at SGO and showed the olaparib had a response rate of 20%. So again, looking at a different PARP inhibitor in this particular case. So there's a lot of different trials that are out there with different PARP inhibitors. SOLO-1 is in frontline therapy, and then we have a number of trials that are in platinum-sensitive disease, and Ursula is going to review these in detail, so I'm not going to go into the schemata or anything here. But it gives you an idea of, you have rucaparib, niraparib, I mentioned veliparib, and olaparib, they're all under development. So let's look at some of the existing data that has shaped our current landscape. This is an important trial that randomized patients that were BRCA1 or 2 germline carriers who had progressive or recurrent disease less than 12 months after previous platinum-based chemotherapy. So fairly prescriptive audience here. Primary objective of this study was to look at the PFS of 2 dose levels of olaparib versus pegylated liposomal doxorubicin. So these patients were randomized 1:1:1 to olaparib at 200 milligrams BID, given every 28 days, of course, PO, or 400 milligrams BID at 28-day cycles, or PLD at 50 milligrams per meter squared, given at every 4 weeks. And they treated these patients until progression or withdrawal for other reasons. And for those patients who were treated in the PLD group, they were allowed to cross over to the olaparib 400 milligram BID group if they had progression of disease. This shows the differences here between the curves. And what's really quite interesting is that the olaparib actually performed quite well. What happened was the PLD performed much better than would be expected. So the expected PLD performance rate was almost half of what occurred. And so you saw very good progression that was very close to one another in terms of the progression-free survivals for each of these particular compounds. The 400 milligram per meter squared again had the highest response rate. The last time we went between 400 and 100, the study looked at 400 versus 200. And a lot of ways of interpreting this data. Some people see this as a negative trial. I see this as a trial that shows that you could do, you could also treat these patients with a PARP inhibitor and do as well as one of the best drugs we have for recurrent ovarian cancer. So I think that certainly it's a matter of perspective. If we look at RECIST response, the response rate was the highest in the olaparib 400 milligram per meter squared group with 31% response rate, with 26% response rate for 200 milligrams, and then PLD had a 19% response rate. So it gives you a little bit of an idea there in terms of what you see with clinical activity. Study 19 was a randomized trial that took patients with platinum-sensitive high-grade serous cancer with greater than or equal to 2 previous platinum regimens and randomized these patients to olaparib 400 milligrams BID or placebo. And so these were patients that had a maintained PR or CR and were then randomized. And primary endpoint for this was PFS by RECIST criteria. Secondary endpoints were time to progression by CA-125. They also looked at overall survival and safety. So if we look here, you see that clearly the group that received the olaparib did tremendously better in terms of median progression-free survival of 8.4 versus 4.8 months. Very impressive hazard ratio and highly statistically significant. And this was reported by Jonathan Letterman, first at ASCO in 2011, and then the publication came out in the New England Journal of Medicine in 2012. If we look at the adverse events associated with this trial, you can see that the most common adverse events were nausea, fatigue, followed by vomiting, diarrhea, and anemia was down the course. So if we look at the progression-free survival by BRCA mutation status, this data becomes even more profound in terms of the differences that you see. So those patients that were treated with olaparib versus placebo had a tremendous improvement in progression-free survival with hazard ratios that were most impressive. One of the most impressive hazard ratios, in fact, I've ever seen, of 0.18. So very impressive. Overall survival, however, was not significantly different for the whole group there, as you can see. And obviously, you get into a number of reasons of why that may be, that, again, these patients respond to subsequent therapy well. Any DNA-damaging drug that's given afterwards is something that they're certainly going to do well with. Time to second subsequent therapy, so-called PFS2, was certainly improved. Again, if you were a BRCA mutant patient who was treated with the olaparib compared to placebo, you did significantly better. So again, a large amount of phase 3 development is underway, and this is looking at a number of the trials that are out there, and I alluded to some of these, and Ursula is going to speak to most of these as we move forward. This is looking at some of the anti-tumor activity that has been reported for niraparib, looking at a phase 1/2, looking at the breakout here, and again, seeing both platinum-resistant and sensitive patients that respond to these drugs. and fairly robust activity that's seen with this PARP inhibitor as well. We have the Kaufman data that really was the formation in terms of the efficacy, at least, for olaparib approval that we had in December of this past year, in 2014, with an overall response rate of 31%. And again, looking at the concept of taking olaparib and combining it with other agents. This was the big splash at ASCO last year, in which we saw the cediranib and olaparib data put together, and quite interesting in terms of looking at these in combination versus olaparib alone. So it was a randomized trial of olaparib versus cediranib plus olaparib, and you can see the combination certainly performed better. If we break it out by BRCA mutation carriers, you see that those that were non-carriers had the biggest benefit from the combination therapy. Those that had a mutation did pretty well on olaparib alone, quite frankly. And if you factor in the toxicity difference with the combination having higher toxicity, it's hard to argue for that combination in those patients. Again, a number of trials forthcoming, and we'll get into most of these as we move forward. So I'll leave it at that. And again, more trials, more combinations. So there's a great deal of enthusiasm for carrying these results forward and looking at these different drugs in different settings. So in summary, we certainly see activity for those patients who have BRCA germline mutations, and it also appears to be active in those with BRCA dysfunction from other genes that can be mutated that have a link to homologous repair deficiency. So we know there's at least 13 genes that are out there. You have the RAD51, C and D. You have a number of check inhibitors, 1 and 2, as well as some other genes, the ATM, et cetera, that have all been implicated in deficient homologous repair. And these genes have all been shown, when present, to predict PARP response. And so this is an area of active investigation as we move forward. Long-term safety data is still pending, so we have great data for short-term, but we don't have the long-term effects, especially for patients that would be considered to be on maintenance therapy for a prolonged period of time. What would be the long-term effects? What if these patients are cured and are alive in 5 to 10 years? Will we see any long-term effects? Synthetic lethality is a new paradigm, and PARP inhibitors are being studied in multiple settings, as I mentioned, and ongoing trials with these and other biologics, I think, will really be quite informative as we move forward in terms of trying to improve the outcome for women with BRCA mutations afflicted with ovarian cancer. Thank you.
So Tom, that was excellent. You shared with us a whole bunch of data, quite honestly, that's been evolving over almost a decade. You talked about 4 PARP inhibitors, olaparib, which is FDA approved, 3 that are in development, rucaparib, veliparib, and niraparib. Is it possible for you to say that one is better than the other, or one is more toxic, or is that just too premature? Because that's really what we want to know, right? Because this is becoming a very congested space.
I wish I had a crystal ball. I'd be able to tell you who's going to win the hockey game, and I'd be able to tell you which of these PARPs is going to emerge. I think there's going to be a place for a number of these PARPs. I think they show such good activity. The landscape moving forward will be quite interesting, and I think it's going to depend on a lot of strategic decisions by the individual pharmaceutical companies in terms of positioning, as well as the number of resources they put into it for different indications and lines of therapies and so forth. If we look at it from a basic science standpoint in terms of the kilodaltons, the pharmacokinetics, the class effect toxicities that we see, they don't appear to be all that different from one another in terms of the ability to inhibit PARP. There's some that have been alluded to that do better with trapping, and there's some other subtleties in terms of mechanism of action that people have suggested may be important. But so far, I don't know if we have a real strong understanding of at least the 3 or 4 ones that are furthest along in clinical development of whether they're going to be substantially different from one another.
And there'd be a 5th one, the BioMarin, which is phase 3 in breast. So Ursula, are these molecules more the same or more different? Can you just at least boil that down?
I think they're probably more the same.
Okay.
Just because of mechanism of action, certainly class effect toxicities. And I think, just as Tom said, it's going to depend upon how these drugs are developed, the clinical trials that you just talked about, the ones I'll talk about, where they end up landing in treatment.
And tell us, what do we know about leukemia? So Tom alluded to the long-term safety. There's some questions. There's been lots of discussion and conversation about acute myeloid leukemia and MDS. Either one of you, where do we stand on that?
We'll both comment. The myelodysplastic syndrome and the leukemias are something that we certainly need to continue to watch. It certainly makes sense that these could emerge from compounds that have the mechanism of action that PARP inhibition renders. However, you also have difficulty in separating that from the problems that you see just with treatment from ovarian cancer. So you give DNA damaging agents from the beginning, and many of these patients will respond to a large number of lines of therapy. And so you take patients that have 4, 5, 6 lines of therapy, and they're at high risk for developing these particular toxicities anyway. So I think we have to be mindful of trying to separate out what the background noise is versus the increased signal.
Yeah, I would completely agree. I think the patients I've seen who've developed secondary leukemias or MDS have been those who've had underlying germline BRCA mutations. They just have this innate inability to repair DNA properly. So you just have to be very careful about platinums, PARP inhibitors, alkylating agents, etc.
So why, there's a question, why do you think that the non-germline BRCA mutation patients respond? In other words, if it's all about BRCA, why do the germline normal BRCAs respond?
Because so I think as Brad, as you showed in one of your slides, not only does PARP come in as kind of this ambulance to help repair DNA, but there are a host of other molecules involved in DNA repair, and either single mutations within those genes of those molecules that are involved in DNA repair, or possibly multiple. Certainly can give rise to enhanced platinum sensitivity of ovarian cancer, and hence PARP sensitivity enhancement. Liz Swisher showed that in CCR a couple of years ago, a nice paper.
Okay. So let's go ahead and do some cases. I'm interested in your feedback. We have 3 cases. I'm going to do the first one, and then we're going to turn it over to Ursula, and then Dr. Herzog, Tom can do the third. So this is a patient, a 61-year-old woman with high-grade serous cancer who 4 years ago almost had an operation. Had, carboplatin paclitaxel twice. The bevacizumab was continued a la the Oceans protocol. She had some progression and then rifled through these non-platinum agents, liposomal doxorubicin, weekly paclitaxel, topotecan, even had an area that was symptomatic radiated. So that's 1, 2, 3, 4, 5, 6 regimens, and now gets her 7th regimen, gemcitabine cisplatin, and has another response, 3rd response to platinum. Not uncommon. And then someone has the brilliant idea, well, let's go ahead and do BRCA testing. This is exactly the sort of patient that should have a BRCA mutation. And indeed, she has a germline mutation, okay? But she is in remission now. Or at least she's had essentially a remission from her 3rd line platinum treatment. So she has the mutation, and she's had 7 lines of treatment, but this is a maintenance sort of situation. So what is the next best step for this patient? Well, obviously you could do a LAPRA, but you saw that many of you, may not get paid. Retreatment with bevacizumab. Remember, she had bevacizumab 4 lines of therapy ago, and it worked. Or additional cytotoxic chemotherapy, or will you say, she's had a good response to her 3rd platinum, I'm going to sit and wait. Yeah, so even though many of you have not tried, you kind of want to do it because she's BRCA germline mutation positive, but she's had a response, and so it would technically be maintenance off-label. And certainly because she's had a response, many of you would do, quite honestly, what might be appropriate. Certainly it would be observation. This is study 19. Dr. Herzog presented it. This patient that I presented to you would have been eligible for study 19 if this was the era that she was diagnosed. This has been published now 3 years ago. And in the BRCA germline mutation cohort, remember, study 19 was maintenance, at least 2 priors. This woman had had 3 prior platinums, 7 prior regimens. The hazard ratio is 0.18. Some people say it's 0.17 because it was analyzed twice. But that's almost a tripling of the PFS from 4.3 to 11.2 months. So I get it why half of you wanted to use it in this scenario, because this trial is exactly what we're dealing with. And in fact, there was an ODAC for this indication, okay, June 25th, and the vote was negative. So the company felt, and there were patient advocates that testified at that they should get it approved. And indeed, this is the European label, but it's not the label here. And there are other companies that are doing exactly the same thing. Niraparib, this study has completed enrollment. Again, same scenario, another PARP inhibitor, and you'll see these data probably within the next 6 months, so very, very intriguing. And other companies, right? So Olaparib is doing a confirmatory trial. We talked about Niraparib, and then Rucaparib is the third. So this platinum-sensitive maintenance setting is fertile ground, but also highly, highly competitive. But that's not the label. The label is monotherapy in patients with deleterious or suspected BRCA-mutated advanced ovarian cancer, and it's an accelerated approval which has some regulatory stipulations, and the dose is 400 milligrams orally twice a day, okay? Dose reductions go to 200, or 100 would be the second dose reduction. And the study is based on the Kaufman paper that Dr. Herzog referred to. This was 298 patients with ovarian cancer. But ultimately, when you boil it, and again, at least 3 prior regimens, if you boil it down to the measurable disease cohort, excuse me, this is the ovarian cancer cohort. I'm going to go back a slide. So the 298 is different tumor types. The 193 was ovarian cancer, 31% response rate. But if you take the 137 with measurable disease, and this is the label, you got to have 3 things: 3 lines of treatment, measurable disease, and BRCA germline mutation. And this is the group from that subset of patients on the Kaufman trial. 137 patients had a 34% response rate. And the reason that it led to accelerated approval is what you see there is almost an 8-month durable response rate. So pretty impressive. And again, this is 4th line and beyond. The adverse events, I think, was also a question. Any adverse event was relatively low, grade 3-4, but there was some fatigue, headache, and anemia. But the Achilles heel really, and that was a question, is GI toxicity. The nausea, vomiting, diarrhea, decreased appetite, dyspepsia. So it's very important, I think, to be proactive when you use Olaparib. I begin everyone on an antacid, so a Protonix or an H2 blocker, and I have them in their possession, prescription filled, ondansetron for nausea and loperamide for diarrhea should it occur. And if it's severe, I discontinue, and if it's temporarily, and it'll get better because it generally happens early on, and ultimately restart depending on the severity of dose reduction. So that's the first case. Let's turn it over to the second case. Go ahead, Dr. Marcelonis. Thank you.
Okay, so my first discussion with you guys is the case. So this is a 42-year-old woman, business owner, and when she presented, her initial presentation presented with a axillary lymph node, and she also had a history of node-negative melanoma in the past. An FNA of the axillary lymph node was consistent with high-grade serous cancer. And she also had, obviously, a concomitant CT scan, which showed 8-centimeter pelvic mass and peritoneal disease. She went up front surgery, was optimally cytoreduced, and had an axillary lymph node dissection on that side, and was diagnosed with stage 4 high-grade serous ovarian cancer. She was also found to have a germline BRCA2 mutation, and also underwent bilateral mastectomies. Her initial treatment plan was 6 cycles of intravenous carboplatin and paclitaxel every 3 weeks. So at follow-up, her CENA-5 was 420 at cycle 1, immediately post-operative, and then normalized to 8 by cycle number 6. She was in remission for 18 months, and then her CA-125 on routine every 3-month assessment was up to 80. She then had a CAT scan showing new retroperitoneal adenopathy and peritoneal disease. She went on to receive carboplatin and liposomal doxorubicin, but only received 4 cycles because of thrombocytopenia and neutropenia. And in fact, cycles 2, 3, and 4 were delayed at least a week each because of low platelet counts. 14 months later, after she finished her 4 cycles of carbo-liposomal doxorubicin, she started noticing progressive shortness of breath and also some mild abdominal bloating, and was found to have bilateral pleural effusions and peritoneal carcinomatosis, as you can see on these scans. She underwent thoracentesis, and the cytology was positive for adenocarcinoma. PAX8 was positive for IHC, consistent with high-grade serous ovarian cancer recurrence. She then started on single-agent carboplatin intravenously. After 3 cycles of carboplatin, her CA125 dropped from 500 down to 150, and her shortness of breath improved, as did her abdominal symptoms. You decided to continue carboplatin until maximum response, and that was anywhere between 6 and 10 cycles. You can decide that. And then your plan is to restage her with another CAT scan. So after the carboplatin has been completed, whatever that ends up being, between 6 and 10 cycles, what is the next best step for her treatment? 1, as long as there is no evidence of progression, offer her a break from treatment. If cancer is still present, start olaparib. If cancer is still present, start bevacizumab. If cancer is still present, start olaparib and bevacizumab together. So number 2, so if a cancer is still present, start olaparib. I think that is very reasonable. I think as long as, if she doesn't have cancer present, if you get a CR, which again would be pretty rare, but certainly could happen. But if there's cancer present there, I agree, that would be my choice. I have certainly started to see some physicians use olaparib and bevacizumab together. So that practice is out there. But obviously the label, as Brad mentioned, is olaparib alone. Okay, next slide. So after completing 6 cycles of carboplatin, she undergoes a repeat CAT scan that shows smaller but persistent bilateral pleural effusions and peritoneal disease. So you decide to give her olaparib, 400 milligrams twice daily using the capsule formation, which she agrees to. Her starting CBC shows an ANC of 1800, hemoglobin's 10.4, crits 31, and her platelet count's 190. You see her back monthly for a CBC, other lab tests, physical exam, and a CA125 level. Oh, I gotta press the button here. 3 months later, her CBC shows the following: ANC is 1600, platelets are 193, hemoglobin's down to 8, hematocrit's 24%. She's fatigued but still working, but her CA125 now is 30, and her cancer-related symptoms have resolved. She really didn't have many to begin with, but her CA125 is now in good shape. So what's the next best step in therapy now? 1, give 2 units of packed red blood cells and continue olaparib at 400 twice daily. Number 2, hold olaparib until her hematocrit and hemoglobin improve, and then restart olaparib at a lower dose of 200 twice a day. Decrease the dose to 200 twice a day and restart right away, or stop olaparib. So no, I don't think I would have given one. I'm not a fan of using red cells unless you really have to, as I'm sure most of us are in this room. I basically said that she was tired, but she was able to work. And I think that number 2 or number 3 would be appropriate, and it really ends up being a discussion with the patient what she wants to do. I think if you said number 3, then you'd want to bring her back in 2 weeks later or so just to recheck her hematocrit. But I think younger patients can certainly tolerate lower hemoglobins and hematocrits. Certainly, whoever said stop olaparib, No, I wouldn't stop olaparib. I mean, she's having a good response. She's tolerating it well. These are the kind of toxicities that that one can manage, and I know Tom is going to talk about some of the gastrointestinal toxicities. I think that was my last one. Yep.
So Ursula, let me ask a question while you're up there. So how about EPO? You know, in the olden days, I'm old. That would be the ideal patient for EPO.
Yep. Right.
Do you use EPO in your oncology practice?
I can't think of the last time I prescribed it. So no, I don't use it. I don't use it at all. It's completely gone out of my practice. Yeah.
Tom, do you use EPO at all?
I used to use a fair amount of it, and since the black box warning and all the things that you have to jump through now, the hoops, you know, in this particular setting, you could certainly do it. We've gotten out of the habit of doing it because with frontline therapy, it's supposed to be for non-curative intent. And,
right.
And for me to look a patient in the face with frontline therapy, and she says, well, wait a minute, I just signed something that says here you're not trying to cure me.
Right.
That gets me into a quandary I'd rather not be in.
How would you handle that anemic patient, that hemoglobin of age, not terribly symptomatic, but she can work, but she tells you in the office that, look, I'm tired, and her hemoglobin's at 8, but she's responding at 400.
Yes, so I'd hold and decrease. I'd hold until you get a little recovery, give her some iron, and then consider dose reduction.
And I don't know the right answer to that, but I would kind of like to keep her on treatment because she's having such a good response. You would keep her treatment, yeah. But you said you'd hold.
Well, I'd hold until she has a little recovery,
right.
And then I'd resume treatment. I wouldn't discontinue. Hold.
Oh, I understand. I got you. Personally, again, I know right answer. I just give her blood and move on. I mean, the good news about blood is it always works, and it's safe and it's cheap. So I mean, I don't know. Maybe it's because I'm a surgeon and you lose too much blood in the OR.
You're used to doing a lot of transfusions.
That's my point, right? All right. So Tom, why don't you go ahead and give us our next case?
So I'm going to look at this from the GI toxicity standpoint a little bit. We're going to do a case here. So a 45-year-old woman with stage 3C ovarian cancer. She underwent a total abdominal hysterectomy, bilateral salpingo-oophorectomy, omentectomy, and tumor debulking to R0, meaning she had no gross residual disease. She was then treated with 6 cycles of carboplatin paclitaxel, had a complete clinical remission, but 12 months later, she developed abdominal pain, swelling, and a rising CA-125. Her performance status was 1. She was treated with an additional 6 cycles of carboplatin PLD after her imaging had shown multifocal disease. She then relapsed again 7 months later after completing treatment. Again, multifocal disease was present on her scan. She underwent genetic testing that was positive for a BRCA1 germline mutation. She was then treated with single-agent pegylated liposomal doxorubicin ×5 with a PR based on CA-125 values. She had some fairly significant skin toxicity, which is why we stopped at 5. She recurred 5 months later, again with multifocal disease on imaging. So what's the best next step in therapy? How would you treat her at this point? Would you give her bevacizumab? Would you give her carbo-gem plus or minus bev? Would you give her a weekly taxane? Would you give her olaparib? Would you give her carboplatin paclitaxel? Would you do something else? Okay, so a lot of enthusiasm for olaparib. There's some enthusiasm for treating her with carbo-gem and bevacizumab, and then a few others. Okay. It's pretty reasonable, I think. Are we going back over these again?
No.
We're not, okay. So I think that's a fairly reasonable approach. Certainly would, I think the 2 answers that were the predominant would be very reasonable. And certainly the fact that she's BRCA positive and has had enough priors, she would qualify then for olaparib as the current label is written. She started on olaparib, 400 milligrams POBID, but has grade 2 nausea and vomiting after her 2nd cycle. What's the best next step in her management? Would you stop treatment? Would you hold treatment? Would you reduce the dose? And those can be coupled, obviously. Would you offer her antiemetics, or would you do something else? Okay, so the vast majority would offer antiemetics. Brad, you may have influenced that with what you were saying. Ursula, how much in the way of antiemetics do you routinely give with these compounds?
You know, I think that there are patients that you're gonna see who have had nausea, vomiting with other therapies. So you're going to be able to pick out those patients to a certain extent ahead of time who are going to have significant nausea, vomiting. And I think, you know, you talked about the high degree of nausea and vomiting that have been seen in some of the elaborate trials. I think that we don't have a great way on clinical trials of measuring that. So if you have a patient who has grade 1 nausea 1 day out of a month, that still gets graded as grade 1 nausea for that month, even though if it happened transiently 1 day. So I think that I have not seen that much nausea, vomiting. I've seen more nausea than vomiting. I think that you can tell patients to, you know, probably eat differently. As Brad said, perhaps pre-medicate with you know, some sort of an anti-nausea medicine or a H2 blocker, and try to figure out and strategize with the patient how best to mitigate her symptoms. I don't know. What was your question again? Was that your question?
Yeah. Basically, do you routinely give antiemetics for your patients with olaparib?
You know, a lot of patients will have leftover antiemetics from their previous chemotherapy. I certainly talk to them about nausea and say, if you do develop nausea, you know, take some Compazine or take some Zofran, whatever you have at home. If they don't have anything at home, then I'll certainly give them a prescription prophylactically.
Yeah, grade 2 is a tough one, right? Because if it was grade 3, you'd hold it until it reduces. But there's some grade 2s that you can intervene early enough. And the idea with being proactive and having, you know, antiemetics on hand rather than calling for a prescription is to intervene early rather than hold.
Right. And Brad, again, to clarify, you give it routinely for all patients?
I give them the medication, but I don't have them take it unless they need it. So I write the prescription,
the prescription
for antidiarrheal and antiemetic, but they don't use it unless they need it. I'm a big fan, I think all of us are, that toxicity is not only the grade but the duration. So having, you know, being a little nauseated, not more than a little, but being nauseated 1 day can still be grade 2. But if it really starts to limit the quality of the life, then you need to hold. So early intervention, I think, is the key.
Yep. And my other one point is that the with time these toxicities tend to get better.
So what I've tried to do is give you a little survey here of, I don't know how well this is projecting from the back of the room, probably not too well, especially if you've had a couple glasses of wine. I apologize for the small font. But what we have here is the nausea, vomiting. I've also listed the diarrhea, the abdominal pain, and dyspepsia that you can get along with decreased appetite. So all GI symptomatology. So we wanted to look at all the GI symptomatology that's associated with olaparib in the larger trials. And this of course, is the Kaufman data that Brad alluded to with the 298 patients overall and the 193 in the ovarian cohort. So I focused on the ovarian cohort because ovarian cancer is unique, right? So these patients often have bowel involvement, they often have ascites, they often have had a number of previous treatments that can affect bowel motility, even taxanes perhaps, who knows. But the point is, and they often have adhesions because they've had surgery. So all these things come into play in terms of evaluating GI toxicity. But if you look here, any grade, you're looking at 62% and 39% in terms of nausea and vomiting respectively. So it's certainly pretty high. That's seen there, but as you can see, there's a sudden drop-off to grade 3. So you don't have very much in the way of grade 3 or beyond. It's almost all grade 1 and grade 2. But grade 2 is problematic for a patient. If you have grade 2 nausea, grade 2 vomiting, it's still a problem, and we want to try to control that as much as possible, as well as some of the other symptoms. And I put the overall in there as well. It isn't all that different, but it is lower than what we see with our patients with ovarian cancer in terms of GI distress, which is what you would expect. Here we look at Stan Kay's study where we were looking at olaparib versus PLD, and I thought it was important to show this so you had an understanding of the background of what type of GI dysfunction you might see in general with ovarian cancer, and I think you get a little sense of this with this particular study. So if you look here, again, if you go to grade 3 or greater toxicities, anemia wins, but if you look at all toxicities overall, GI is by far the most common side effect that you have. But if you look here of abdominal pain, Fatigue is at 3%, and then you have nausea at 3% as well. And then compare that, if you look at the olaparib 400 milligram per meter squared, or 400 milligram overall arm, you see it's 9% for the fatigue, but 6% for nausea, and that's in both arms, right? So olaparib and PLD. So it's something to keep in mind when you're thinking about this. We think of more nausea, more vomiting, that type of thing, and you have to separate that out again from the background symptomatology you have from someone who has recurrent ovarian cancer, because again, you wouldn't expect a lot of that with PLD, and indeed you see almost the same incidence. And to show you the difference, something you would expect a large amount of is PPE, and you see 34% grade 3 or beyond in this particular study. So it does appear that they were picking up their toxicities. So again, looking at the most common things here, you get the same sense. A high number of grade 1, 2s that drop off very quickly when you move to grade 3, 4. And again, looking at the GI distress, same thing. So again, grade 1, 2 for nausea. Fairly high number of patients that suffered that, and a very low number that had grade 3, 4. And you see that with the vomiting, the diarrhea, decreased appetite, and abdominal pain as well. In terms of the interruptions due to adverse reactions, they had 40 that occurred out of 223. And so you can see the dose reductions due to adverse reactions and discontinuations due to adverse reactions were relatively low. So Brad already covered the dose reductions that are seen. So the recommended dose, again, is 400 milligrams. One thing we didn't talk a lot about is the fact that many of these studies, in fact, all the studies I've reported to you thus far in terms of resulted studies, have all been with the capsules. And as we move towards the tablets, will that change tolerance? Will that change toxicity profile at all? That'll be an interesting area. And then there's a 50% dose reduction with one dose reduction and another 50% dose reduction with the second dose reduction. It's also recommended that you avoid other CYP3A inhibitors such as grapefruit and Seville oranges. So these are all things to counsel your patient in terms of trying to mitigate the toxicities that you see from the GI tract with PARP inhibition. Thank you.
Thank you. Thanks, Tom. So Ursula, I want your opinion. One of the questions is about the food effect. So Tom said very nicely that these are 50 milligram capsules, which is, 8 in the morning and 8 in the evening. Is there a food effect, and would it behoove the patient to take this with food and not on an empty stomach?
So patients, in the package insert, patients can have a light meal, just prior to taking it. So just a small amount of food, but I wouldn't have them take a large meal. So they can have something on their stomach.
And that probably, at least for most individuals, taking something on a light meal, if you will, with a little bit of food might mitigate some of the nausea.
Exactly,
Okay.
Correct.
All right, so now we're going to hear from Dr. Marcelonis about ongoing studies, trials that are in progress, hopefully that many of you are already participating in, and if not, we invite you to participate in them.
So I'm going to talk about the ongoing trials that a lot have been talked about already, so I'll be hopefully able to go through that relatively quickly. So the learning objective is to review currently open PARP inhibitor trials, and I'm going to really focus on either single-agent PARP inhibitor studies or PARP inhibitor studies that combine PARP inhibitors with biologic agents, and then how to select patients for appropriate studies that are really best for them. Those are my disclosures. This is a review. You've heard about the different PARP inhibitors: olaparib, veliparib, rucaparib, niraparib, and talazoparib, or we could still VMN 673, which is not in any registration type of trials, but is open for some at least one trial for ovarian cancer. So I'm going to run through lists of trials and basically update you where they are, what their origins are, and talk about trial design and eligibility. So for there are several now single-agent trials for recurrent ovarian cancer. So I'm going to talk about single-agent studies for recurrent cancer and single-agent studies for newly diagnosed ovarian cancer. So this slide talks about recurrent cancer. So olaparib is in SOLO 2. I'm going to make the use of this little green arrow. You've already heard about that. This is study 19, except larger and solely in patients with germline BRCA mutations. So this is a olaparib versus placebo study, 2-to-1 randomization in patients who've just completed platinum-based chemotherapy for recurrent platinum-sensitive ovarian cancer. And that has completed accrual, and certainly await the results of this. SOLO 3 is just starting up. It's a phase 3 trial solely in germline BRCA ovarian cancer. And all of the phase 3 studies for olaparib are all in germline BRCA ovarian cancer. This is olaparib versus single-agent chemotherapy, the physician's choice, in patients with platinum-sensitive relapsed BRCA ovarian cancer. And then there's another phase 3 study that's just opening up, just got placed on clinicaltrials.gov, which looks at patients who have non-BRCA but do have mutations within other genes that are involved in DNA repair. So this is olaparib versus placebo as maintenance for patients with platinum-sensitive recurrent ovarian cancer, and this cancer has to harbor a somatic BRCA or deleterious mutation in non-BRCA homologous recombination repair associated genes, so PAL-B, RAD51, other genes that are involved in DNA repair. Niraparib, you already heard from Tom Herzog, the NOVA study, and also Brad mentioned this phase 3 study of niraparib versus placebo as maintenance in both BRCA or non-BRCA high-grade serous ovarian cancer. So this is SOLO 2, except now also incorporating patients who do not have germline BRCA mutation but are wild type, but have high-grade serous ovarian cancer, again, platinum-sensitive recurrence. There's also another niraparib study ongoing, single-agent trial for patients who have recurrent ovarian cancer and have received at least 3 lines of prior chemotherapy. And these are predominantly in patients who do not have an underlying germline mutation. So I think, about a year ago, patients would come to us and say, well, are there PARP inhibitor trials? And we would say no. Now there's really a real plethora, and it's really important to understand the subtleties in terms of eligibility and then the phase. So this already you see an example of trial eligibility for patients who have germline BRCA mutations, but also who do not have germline BRCA mutations. Rucaparib, we've also talked about. Aerial 2, nice data was presented at the ERTC-NCI meeting by Liz Swisher last year. There's a poster on Aerial 2 today. There's going to be an oral presentation on Aerial 2 data, updated data from Liz's presentation on Monday. And that's a phase 2 trial of rucaparib alone in patients who mostly have non-BRCA, basically trying to define a patient population where this drug will be useful if patients do not have an underlying germline BRCA mutation. Aerial 3 is very similar to NOVA. And then there's an ongoing phase 1 trial that's almost done, basically looking at rucaparib in patients with germline BRCA mutations. So in terms of Aerial 2, this is a phase 2 trial. The primary objective is to prospectively identify ovarian cancer patients who are likely to respond to rucaparib. The key eligibility are high-grade serous endometrioid cancer. They have to have platinum-sensitive disease and no prior PARP inhibitor. This is the dose of rucaparib, standard dose derived by the phase 1 trial, 180 patients, and that has now been expanded. We have Aerial 2 open at our institution. There's an extra 200 patients being placed on. And this is from Liz's presentation, and this is going to be updated on Monday. There's 61% response rate in patients who have germline BRCA mutations. For patients who are BRCA wild type but have this BRCA-like signature, it's a 32% response rate, so it drops down but is quite good. And then in patients who do not have a BRCA mutation and also do not have this BRCA-like signature, is an 8% response rate. And this is another area of study, as Tom and Brad have already alluded to, of trying to define the patient who does not have a germline BRCA mutation but has high-grade serous cancer, and which of those patients will respond to PARP inhibitors. And then lastly, the BioMarin compound. There is a PARP after PARP trial open at the NCI. If it's not open, it's open in the next few weeks. And this is basically using the BioMarin compound just on the heels of receipt and progression through another PARP inhibitor, such as olaparib, rucaparib, or niraparib. And Jungmin Lee is running that study. These are the trials that are open for newly diagnosed ovarian cancer. So PARP inhibitors are entering that field. We have obviously no results of this. SOLO-1 has already been discussed. This is again a 2-to-1 randomization of either olaparib versus placebo in patients who have underlying, again, this is a olaparib trial, so germline BRCA mutation and have ovarian cancer. It's all stages. And then Catherine Bell-McGuinn on Monday will be presenting the phase 1 data that's led to this phase 3 trial that's being run through NRG. So the phase 3 study is looking at the incorporation of veliparib into upfront management of patients with recurrent ovarian cancer. So SOLO-1 has completed accrual. We're waiting on results. And the veliparib trial is now just starting and obviously will take some time to accrue. Those are the 2 trials that are at least in play now for newly diagnosed ovarian cancer. Our group, Dana-Farber, has been very interested in PARP inhibitor combinations, and I'm going to go through some of the trial rationale and some of these results. You've already heard about the first combination from Tom already, and I'll briefly mention this. So Joyce Lee, you and I, probably about 2008, while she was still a fellow, were kind of kicking around ideas to put in for a CTEP concept, and noted that olaparib had activity in ovarian cancer, as did cediranib. So we put into the CTEP pool a combination trial looking at olaparib and cediranib. We had some preclinical activity that might be a good thing to do, but in the last now 7 years, more data has been available, and these 2 figures on the right are courtesy of Elise Cohn from the NCI, showing preclinical data that if you put the 2 drugs together, both the PARP inhibitor and the anti-VEGF receptor inhibitor, you do get decreased cell invasion, and the same is also true for microvascular cell tube organization. So this is the trial as a phase 1 originally. Again, we received stimulus funding from the NCI to do this trial, which then led into a randomized phase 2 study of cediranib olaparib versus olaparib alone. Started back in 2009. It was a 2009 trial, and found that the recommended phase 2 dose was cediranib 30 milligrams a day and olaparib 200 milligrams a day. And I'll show you in a few minutes that there are going to be a number of trials launched with this combination of therapy. This was the initial phase 1 results, and we were certainly very happy to see that the waterfall plot was so in favor of responses, and this was both in the BRCA carriers, but also in wild type as well. The overall response rate of the cediranib olaparib combination was 44%. This led then to the phase 2 design, which again Tom has mentioned already, had a total accrual of 90 patients. It was a multi-center phase 2 trial supported by the NCI, randomized 1-to-1. It was not blinded, of olaparib 400 twice a day versus our recommended phase 2 dose from the phase 1 trial, and PFS was the primary endpoint. This is all of the patients showing an improvement in progression-free survival for patients receiving cediranib olaparib 17.7 months versus 9 months for olaparib. And then when we broke down and took a look at a retrospective subset analysis for BRCA mutation carriers, really not a huge difference between cediranib olaparib versus olaparib. For those patients who were either negative or unknown, there was a significant difference in favor of the combination. And again, Tom has shown this data already. So this now has led to several trials that are in different processes of opening, either through NRG or ETCTN. So this is the phase 2, we call it the biomarker study, CTEP 9825. This will be essentially very much like the Clovis trial, Ariel 2, looking for a biomarker to try to predict which patients who do not have a germline mutation but have high-grade cancer will respond to this combination. And then there's a phase 3 study run by Joyce Liu and myself looking at the combination versus olaparib versus platinum doublet in patients with platinum-sensitive recurrent ovarian cancer. Jungmin Lee and Angela Secord will be running a phase 2, phase 3 of this combination in platinum-resistant ovarian cancer. And there's also trials, Ahmed Oza and his group up in Toronto are about to start a trial of the combination post-olaparib, and he just told me today post-PARP inhibitor progression, so it's not restricted to just olaparib. And ICON 9, Jonathan Letterman at the poster discussion session this afternoon also mentioned ICON 9, and that will be using olaparib cediranib in patients with platinum-sensitive recurrent ovarian cancer after receipt of a platinum-based chemotherapy. The Paola trial also uses olaparib, but it uses bevacizumab as a VEGF receptor inhibitor or VEGF inhibitor as opposed to cediranib, and that is not open yet. But again, the design of that is based upon the cediranib olaparib results. This is just briefly NRG GY004, which is the platinum-sensitive concept. Patients are randomized either olaparib monotherapy, the combination, or platinum-based chemotherapy based upon investigator and patient discussion. And this has, again, been approved by the NCI-GYN Steering Committee and hopefully will be open by the end of this year. Niraparib has also has a trial run by our Danish colleagues through NGOT, and this will be niraparib and or niraparib bevacizumab combination against bevacizumab alone. And this is the Avanova trial that is in the phase 1 portion right now, but has not yet moved to the phase 2, and this will be the phase 2 design. Briefly, in the next minute or so, or 2 minutes, I'll talk about another combination using PARP inhibitors and PI3 kinase pathway inhibitors. These are the different trials that have either been reported out or ongoing. So our group with Stand Up to Cancer support has looked at either BKM120 or BYL719, both of which are oral PI3 kinase inhibitors, in combination with olaparib. Tim Yap, also at the same session I presented at AACR, is using the AKT inhibitor AZD5363 with olaparib, and there's an ongoing or about to open trial at MD Anderson looking at the AZD5363 or 2014, which is TORC1-2, in combination with olaparib. And there's good justification for doing this. Certainly for the Cancer Genome Atlas project has shown that about 50% of high-grade serous ovarian cancers harbor defects in DNA repair, but also about 50% have signaling pathway problems with PI3 kinase and RAS. My colleague next door at the Beth Israel Deaconess Hospital, Gerberg Wolf, has done extensive data in addition to Jose Bezelga, showing preclinical in vivo synergy of BKM120 and olaparib. The combination arm are these, whereas the yellow and green represent single agent alone. So I won't go into this because I'm over time already, but this was data that I presented at AACR of BKM120 and olaparib showing DLT toxicities of transaminitis and also depression. BKM120 is a PI3 kinase inhibitor that actually crosses the blood-brain barrier. But this is the waterfall plot that we've seen. This was a trial both in ovarian cancer as well as breast cancer, showing activity of this combination and also showing durations of response in some patients that exceeded 1 year. The other combination of PARP inhibitors are with other DNA repair inhibitors, and there is an ongoing study of olaparib plus AZD6738, which is an ATR inhibitor, and certainly combining PARP inhibitors with other molecules that inhibit other aspects of DNA repair certainly I think are very potentially exciting. So future combinations, PARP inhibitors combined with, we've talked about a number of different ones, but also HSP90 inhibitors, other DNA repair inhibitors such as ATR inhibitors, and obviously what most of this meeting has been about have been the immune checkpoint blockade inhibitors. Certainly there's been interest in combining these agents with PARP inhibitors given potential synergy. The advantages of combination therapy are to avoid the myelosuppression that has been seen in PARP inhibitor chemotherapy combinations. They're mostly by-mouth regimens. This is where we can really start to personalize therapy for our patients and also mitigate and understand resistance strategies. Disadvantages include overlapping toxicities, understanding how basically to hit the target and how do we measure that appropriately and quantify this, and then potential drug-drug interactions. Also, part of my talk was to talk about characteristics of good candidates for clinical trials. I think we've talked about that already. Obviously, you have to meet eligibility and exclusion criteria. You need a patient who's willing to go on trials, got a good PS, normal organ function, not been heavily pretreated, although there are trials that I've discussed tonight where there's no line limit, especially on phase 1 trials. And certainly someone who's not going to be burdened financially or psychologically by the trial. Additional considerations that patients need to have measurable cancer, usually by RECIST 1.1. And again, making sure that that trial is an appropriate next step in her therapy and that it makes sense clinically. These are how to refer patients. Clinicaltrials.gov is a great resource to find trials. NRG website, hospital websites, cancer.gov, centerwatch.com, and certainly having connections with academic centers to quiz physicians and their research study teams about open trials. There's a summary and key points. There are a multitude of current ongoing PARP inhibitor trials. These are really, I think, one of the most exciting therapies in ovarian cancer. We talked about selecting correct patients, and then once selected, what's important to enrolling these patients. So I'm going to stop right there.
Thank you. Thank you very much. So a couple of comments to some of the questions. I think you saw the signal of PD-1 in colorectal cancer where there was mismatched repair signature. So certainly there's rationale of combining immunotherapy checkpoint inhibitor in patients along with PARP inhibition. It was mentioned here on the question that there was an announcement today, for example, that niraparib, Tesaro, was announced a collaboration with pembrolizumab and Merck. That's a preliminary study which will be simply a phase 1, ultimately in phase 1b or phase 2 expansion, depending on how you label it. The other combination that you talked about, not all angiogenesis molecules are the same. The beauty of cediranib and olaparib is it's the same company. So someone asked, how about pazopanib? Well, pazopanib is now owned by Novartis, and there's intellectual property competition. It's a miracle that bevacizumab and olaparib have come together in the Paola trial in frontline maintenance. And then finally, there's no commercially available test to look at genetic scarring. There was a question about how does the Clovis rucaparib companion diagnostic compare to the niraparib companion diagnostic. Well, the companion diagnostic that's integrated into the Ariel trials, the Clovis trials, is basically pure loss of LOH, loss of heterozygosity. The niraparib companion diagnostic that is in study is the Myriad test, which is called My Choice. There's an abstract here in breast cancer, and My Choice by Myriad is 3 components, certainly LOH, like the University of Washington rucaparib Ariel test, but also telomeric allelic imbalance and large-scale state transition. So it's a little bit broader test. Who knows whether it's any better. All right, well, so thank you all for being with us. It's been our pleasure. These are exciting times. These are new agents. These are new diagnostic tests. I want to thank Dr. Herzog, Dr. Marcelonis for being with us. It's Saturday night in Chicago. Let's go ahead and have some fun. Thank you. Good night.